Good morning. Thank you so much to AWE, specifically Dr. Krinsky, Dr. Nguyen, and Dr. Riker for inviting me to come and share with you on a topic of anticoagulation. I know it's not a very sexy topic, especially among advanced endoscopists in this room, but I think you would all agree that it's actually a very common and pertinent topic that we encounter on a regular basis, especially with the frequency, the prevalence of patient anticoagulation, as well as the frequency by which we do colonoscopy. So I have no disclosure. So as far as the prevalence of anticoagulation in the United States, over the last basically 10 years, there's a significant rise in the number of patients that have been placed on anticoagulation. In fact, from 2014 to 2020, it increased from 5.3 million patients to 7.6 million patients on anticoagulation. And the prevalence increased from 1.7% to 2.3% in the US population. And that translates to 40 to 45% increase in just 6 years. The Medicare population cohort, we see an increase from 2.7 million to 5.2 million from 2011 to 2019. That's basically doubling in numbers, right? And the atrial fibrillation prevalence is 2 to 3 million back in 2010, and currently it's at 6 million with a projected increase of 16 million by 2050. Right, and so as one of our speakers shared earlier, we do quite a bit of colonoscopy in the United States, roughly 15 million colonoscopy performed each year. And now with the increase in number of patients on anticoagulation, this clinical dilemma is actually going to come very commonly. We encounter on a regular basis to make a decision whether we should hold or not hold anticoagulation. And so now this is actually something that had come to light in KP and Kaiser Permanente practice. The question you would ask is, what is an advanced endoscopist doing with anticoagulation? Well, I took over as chief of GI in Orange County in 2016, as well as regional Southern California GI chief, and the clinical pharmacists, specifically anticoagulation pharmacists, reach out to me and ask, Dr. Gap, you got to address this issue with the practice of anticoagulation in our group. We have 23 gastroenterologists, and yet there's significant variation in practice. Some hold, some don't hold, some hold 1 week and don't hold the next week. So it really created a great deal of inefficiency, and so that's why they reach out to me. And as an advanced endoscopist, I admit to you, I didn't know much about this topic, except for basically looking into HGE guidelines. I actually reached out to Dr. Tom Savides back in 2016, 17, and asked him about advice on this topic, and he guided me to the HGE guideline in 2016. So I then reached out to Raman Muthuswamy from UCLA, who sit in the committee, to get guidance as well. So I think the guideline certainly is very helpful, but there's limitation, and I'll share with you at this point. Of course, what are we trying to do? We're trying to balance the risk of bleeding versus the thrombotic risk, right? As far as bleeding, I think most of us certainly can manage this. Basically, patient come in with delayed bleeding, we can repeat a colonoscopy. We do have therapeutic option, whether it's clipping, cauterization, and typically, however, the outcome is rather reversible. We can transfer the patient, support the patient, and subsequently take care of the bleeding source. Thrombotic events, however, are much more catastrophic, right? It leads to permanent disability, irreversible injury, and even mortality risk. So what do the guidelines tell us? The ASGE guideline 2016, the American College of Gastro, and the College of Association in 2022, the European Society guideline, BSG in 2021, all basically balance the risk of the procedure versus the thrombotic and embolic risk. The ASGE guideline basically stated that in 2016, low-risk procedure, we continue with anticoagulation. High-risk procedure, which is most therapeutic stuff that we do in advanced endoscopies, we hold and bridge with with a patient on Coumadin. The European Society guideline and the British Society guideline 2021 basically stated a similar, a recommendation: low risk, continue anticoagulation; high risk, hold anticoagulation. And then the most recent one, which is 2022 guideline, stated that now there's consideration of continued warfarin or Coumadin in patients with elective procedures and for more of a conservative approach in patients with DOACs. So the bottom line guidelines give us guidance. If we know ahead of time that we're going to do a low-risk procedure, right, versus a high-risk procedure, and the high-risk procedure is defined as polypectomy greater than 1 cm, EMR, then of course we hold anticoagulation. whereas low-risk procedure, which include diagnostic colonoscopy with or without biopsy, right? The limitation, however, is this, is that majority of the patient that comes in for a screening colonoscopy, we don't know which one of those buckets they're going to fall into, right? And that's the challenge with us. However, what we do know is that most colonoscopy actually require no intervention, or at least low-risk intervention. That means we can potentially do biopsy in those patients. And yet, the way that we practice in the United States, based on a survey by HE, is that majority of us actually treat everybody as a high risk. We basically hold anticoagulation for all these patients. And so we are interrupting the anticoagulation not because what we know, but because what we think we might find in that colonoscopy, and that's why we stop the anticoagulation. And that's the limitation. Now, however, what do we know about the prevalence of high-risk colonoscopy? And this is actually based on a classic screening study that was published in the VA study, corporate study, that was published in 2000. Advanced adenoma, defined as greater than 1 cm, right, or villus or high-grade dysplasia, only account for about 5 to 7% prevalence. That means 93 to 95% of the patients with colonoscopy come in don't have high-risk lesions or big lesions that require polypectomy for us to take them off. Our own study in KP, and I'm going to share with you the data shortly, showed that 60 to 7% of colonoscopy require no polypectomy, and of course that translates to the patient coming in with adenoma detection rate that we all certainly fully aware of. And among the detected polyps, 86% are actually less than 1 cm. So only 10 to 15% of patients with polyps actually have polyps greater than 1 cm. And again, that translates to 5 to 8% of colonoscopy, very similar to the VA study that was published. So what we discovered is actually we are interrupting the anticoagulation in these patients with the potential increase in the risk of thromboembolic risk, not to mention the indirect cost, which is patient inconvenience, increased cost, and workflow efficiency, which I'll share with you shortly. So back in 2016, I did a deep dive on this. I went back to my team in Orange County, and I asked, you know what, should we really stop on anticoagulation? We debate this issue. The guidelines certainly give us guidance if we know ahead of time, which we don't. So at that point in Orange County, which is one out of the 13 Medi-Surgical Service area in Southern California, KP, we have 4.9 million patients. We have 13 medical service areas. So Orange County, I led that study because the only way I'm able to convince my gastroenterologist whether they should hold or not is that we need to have additional study to demonstrate that it's actually safe. So we proposed this, we basically go back and at that point make a decision that all patients coming in for screening colonoscopy, routine colonoscopy, we are not going to hold anticoagulation. Of course, with the understanding that the patient would finally have a polyp that require polypectomy, we're going to have to bring that patient back, right? And so Orange County went solo on that practice back in 2019. And that's why this study is here. I'm going to demonstrate that study with you. It's a retrospective study. We initially looked at 677,000 patients between the age of 45 and 75. Out of those 20,000, roughly 20,000 are on anticoagulation. We then basically essentially divided into Orange County versus other 12 medical service areas in Southern California. And we have basically come down to is that we have 1,153 patients that were a quarter of a patient before we convert into this model of not interrupting anticoagulation, compared to the other 1,600 after the study of 2019, 2022, that we no longer withholding anticoagulation. Compared to the other medical service area where basically the practice is to withhold. And basically the studies demonstrated that there's no difference in bleeding risk. And of course, the thrombotic risk increase in patients with high electrolyte comorbidity index, as well as in patients with high CHA2DS2-VASc score. And certainly, I think that's something all of us certainly will agree. So based on this study, what we demonstrate is that there's no increase in risk of bleeding. The thromboembolism rate, unfortunately, didn't show a significant increase, or decrease actually, but I do think it has to do with the power of the study. Despite having 1,150 patients, we were not able to demonstrate the power because the incidence of thromboembolic event is still quite low. But what I was able to demonstrate to my gastroenterologist that it is safe to do a colonoscopy without interrupting the anticoagulation, and then potentially lower the risk of thrombotic risk, and there's definitely no increased risk of bleeding. So the next question you would ask in KP, we look at basically essentially the value-added proposition of cost effectiveness. And so we look at the cost of actually interrupting anticoagulation, right? The bridging therapy with low molecular weight heparin costs about between $30 to $30 per dose, and that translates to about $150 to $500 per patient. But the indirect cost is really the nursing, the education, the coordination with pharmacy. That's an inherent cost that you really can't put a price tag on. In addition to that, it's also monitoring patient with anticoagulation. Granted, before COVID, right, most patients actually on, basically Coumadin that require INR checked on a regular basis. But of course, COVID changed that. We essentially now more or less convert all those patients to now DOACs. But despite that, basically when we do have these disruption, that translates to about $50 to $200 per patient. And then, of course, the required calls, instruction, medication adjustment by anticoagulation clinical pharmacists. Post-procedure, of course, we have to restart it, check the INR, and get the patient back on therapeutic level. So there's really a significant amount of hidden costs that associated with this change in, interruption of anticoagulation. So let's look at the actual bleeding cost now, right? The bleeding cost is that a patient come in, we have to do repeat colonoscopy, endoscopic therapy. That basically translates to between $3,000 to $10,000 per event. The thrombotic events, however, are much more costly, right? Now, most of the highest risk is really immediately after we stop the anticoagulation. We're talking about 3 to 7 days before the actually procedure is done. But that's also the window that if they have an event, the patient doesn't even show up for colonoscopy. So gastroenterologists, many of us are not even aware that the patient had a thrombotic event because, again, they didn't show up because they got admitted to the hospital with a stroke or an embolic event, right? So most of us are basically, our optics is a little bit biased in the sense we only see the one that's caused, that we have bleeding patient, but we don't really see the one that come in with a catastrophic event. But in any event, the acute hospitalization is roughly 20 to 40,000. Long-term care costs between 90 to 150,000, based on a cost stroke analysis here. So the actual cost of interrupting anticoagulation, I would argue, is that not just the bridging, the bleeding, the stroke, but the key message I'm hoping to share with the group is that interrupting the anticoagulation is not only clinically questionable at this point, but it's also economically inefficient. We are spending more to potentially cause harm without actually a clear benefit by holding a majority of these patients, right? So there's really asymmetry of risk. The bottom line is not all risks are created equal, right? The bleeding risk are manageable. The thromboembolic risk, however, are catastrophic, right? We treat risk of basically these risks as if they're equal, but they're not, right? So it comes down to is that the clinical decision should really account for not just the frequency of the complication, but the severity and the reversibility of these risks. So the next question you ask, what about from the patient perspective? What do you think about this, right? So what we encounter in Orange County when we have this conversation with the patient is that option A, we're going to hold anticoagulation, but there's a small and the real risk of a stroke and a thromboembolic event. Option B is that we continue anticoagulation for routine screening colonoscopy with a small chance that the patient will need to come back for a second colonoscopy, right? Most patients, when we discuss this with them, they would choose an option B, which is hold anticoagulation, realizing they potentially might be inconvenient to come back for the second colonoscopy and try to avert the risk of a basically catastrophic event. And when we essentially come down to now, I think that the practice of medicine require a shared decision making. And I think certainly in KP we follow that model. So we explain to the patient the risk of bleeding, the risk of thromboembolism, the possibility of repeat procedure, and now we basically let the decision be a patient-centered decision making, right? And when informed, the patient, for the majority, if not all, actually choose the option of continuing with anticoagulation to protect them. So at the end of conclusion, I'm hoping to instill some consideration among all of us is that we should change the paradigm, right? The old model is that we think colonoscopy equal high risk, and therefore hold anticoagulation. To the new model, that most colonoscopy is actually low risk, and that we consider continued anticoagulation. Thank you very much for the attention. Thank you.